Thank you for the invitation, Chairman. And I would like to thanks to the invitation is the last symposium in this beautiful city. This left panel is a bone marrow biopsy of aplastic anemia, in contrast to right panel is a normal donor marrow. And you can see is a very decreased cell rate and rare evaporatic cells and many replacement of fat. Why this happened in this patient? And basically, the main pathology of aplastic anemia is abnormal activation of a cytotoxic T cell, and this is a release of a negative cytokine, including interferon gamma and TNF beta, and to the hematopoietic stem cell, CD34 hematopoietic stem cell, or early progenitor cell. And these cells have eventually received this signal of negative signal, including phospholigand and multi-step molecular pathway inside of a cell, and eventually lead to apoptosis of a stem cell. And the other mechanism of this CTL is expands by the IL-2, and this immune injury is augmented by the expansion of a T cell clone. And as a result, this aplastic anemia is the decreased CD34 positive cells, and the decreased colony formation, and the decreased long-term culture innocent cells compared to normal control. And the clinical manifestation is anemia requiring transfusion, and the neutropenia is a risk of life-threatening infection, and thrombocytopenia risk of bleeding. And the other mechanism of telomerase, which is previous speaker, Dr. Carrado, has the extensive reviewed, so I would like to skip this slide. And the number of patients with aplastic anemia has found as autoantibody against a distinct protein. And for example, kinetin and the anti-phosphomeiotic segregation antibody, and the diazepam binding protein, and the myosin. And 1/3 of patients of aplastic anemia found this autoantibody, suggesting that this patient has also related abnormal T cell response involved in pathogenesis of aplastic anemia. And what is treatment option of aplastic anemia? And stem cell transplant, and the second is immunosuppressive therapy and supportive care. The indication of a transplant is three categories. One is the age factor. As a general recommendation, is below 50, and of course, as a suitable donor present, and in case of a severe or very severe aplastic anemia. So previous case which chairman presented case is a very severe aplastic anemia. Those patients can be transplanted as soon as possible if actually matched donor is present. And the second is immunosuppressive therapy is can be done is otherwise this transplant case. And the general algorithm of treatment, if patient diagnosis acquired aplastic anemia, you have to decide the severity of a patient. Is it severe or non-severe? Sorry. If in case of severe or very severe aplastic anemia, if patient is a younger patient, you can check the HLA test, and HLA test matching donor is present, you should do the transplant as soon as possible. If no, you can go to the immunosuppressive therapy with the ATG plus cyclosporine. And the patient is an older patient, for example, more than 50 years old, as immunosuppressive therapy is done as post-line treatment. If a patient have no response to immunosuppressive therapy, as you can consider the unrelated transplant or second immunosuppressive therapy. In the right side, if patient non-severe patient, if patient transplant dependent, you can go to the immunosuppressive therapy. However, patients with no transplant requirement and a non-severe case, you can see the wait and see. Going back to basic mechanism, basic pathophysiology of aplastic anemia, the rationale of immune suppressive therapy is T-cell elimination. So you can see the ATG is useful for T-cell elimination. And the other thing is the cyclosporin, at the right below, is the cyclosporin also inhibit cytokine-mediated immune suppression, as well as inhibition of IL-2 and IL-2 receptor, and to hopefully to promote hematopoiesis of a CD34 positive cell. And the other potential immune suppression is cyclophosphamide, which is also affect T-cell inhibition, however, as well as CD34 positive cell, so might the risk of prolonged neutropenia. Proposed mechanism of the ATG can interfere the immune responses suggested 5. The first one is T-cell depletion in blood and lymphoid tissue through complement-dependent lysis and T-cell apoptosis. And the second, second is induction of B-cell apoptosis. And the third here is a modulation of a cell surface molecule, including adhesion and the cytokine receptor. And the fourth is here, and the interference with dendritic cell property, including maturation and migration. Finally, this is more important for immune response. The finally is the induction of a regulated T cell and NK T cell. So since 1990s, the randomized study was done to comparing the combination of the ATG plus cyclosporin versus ATG alone to see what is better response and better survival. So first the study was done in German and NIH in US, and the EBMT and the Korean study also demonstrated the combination of ATG plus cyclosporin is a better response to a single arm to ATG or a cyclosporin alone. So since then, the standard recommendation of immune suppressive therapy is a combination of ATG plus cyclosporin. But this study is using the host ATG as a first-line treatment. And the factors for predicting response of IST is the younger age is better response, and the presence of a PNH clone, and the increased reticulocyte or lymphocyte count at diagnosis has a better response to after IST. And early treatment compared to late treatment, for example, within the 3 weeks after diagnosis, has a better response. And also important is the cyclosporin therapy level, and after response followed by a late tapering is also a good response. And the one study from Japan is also the patient with the HLA-DR15 as a good response. And we have the retrospective study for patients with a number of 324 patients receiving IST, evaluate the response factor. So as the other study is consistent, the older age or negative PNH clone is a poor survivor. And abnormal cytogenetics with no dysplasia at diagnosis has also poor response by multiple rate analysis. And the factors to predict a relapse after response of IST is a shorter response, a shorter telomere, as Dr. Collado has discussed. And the rapid tapering of cyclosporin is also a predictor relapse. So the recommendation from the British Society has to tapering cyclosporin by 10% every month, starting at least 1 year from immune suppressive therapy. And of course, suboptimal therapeutic range of cyclosporin is also a risk of relapse. To improve the response of IST to a couple of studies has been made. And the first is the addition of a GCSF, as the chairman has presented this case. And the GCSF, the number of studies comparing the ATG plus cyclosporine with or without GCSF has most study data is improved the neutrophil count with the GCSF group. However, the response of a survivor is similar between both groups. So the general recommendation is that the routine use of a GCSF is not recommended in the acquired aplastic anemia, except case of the life-threatening infection. And the other is that the addition of other immunosuppressive therapy with the ATG plus cyclosporine. The one study, high dose methylprednisolone, has a negative study with increasing toxicity without better response. And the other addition of the drug of mycophenolate of rapamycin sirolimus conducted by NIH from US is also negative study, which means the no better response compared to the ATG plus cyclosporine. And the alternative immunosuppressive regimen is suggested. One is a high-dose cyclophosphamide. This regimen is firstly introduced by Johns Hopkins group. This is 200 milligram per kilo without stem cell rescue trial to aplastic anemia. The initial report is a good response. However, the NIH has a randomized trial to validate this study. This high-dose cytoxan plus cyclosporine versus a standard regimen. However, the cytoxan group has a higher, the low response rate than the standard regimen. And more importantly, the cytoxan group have a higher fungal infection and deaths compared to the ATG plus cyclosporine. So for the safety issue, this NIH study is close to early stop. So now the high-dose cyclosporine cyclophosphamide has not recommended in routine use of IST. And the other drug is alemtuzumab. It's a CD52 monoclonal antibody in CAMPAS, and the first conducted by Europe is a good response to the aplastic anemia. And the recently published in NIH by alemtuzumab in aplastic anemia. This study is a different setting. One is refractory cases, and the other is relapsed cases, and finally the first-line cases. So 37% in refractory aplastic anemia, and 56% of relapsed cases, and only 19% in treatment-naive as a first-line treatment. So they conclude this alemtuzumab has recommended to the refractory or relapsed aplastic anemia, not recommended to the first-line treatment. And in ATG, it's two ATG is present. One is horse ATG, and the other is rabbit ATG. The horse ATG is the well-dose defined, and a number of experience has published. And most study with the first-line treatment for IST is horse ATG. But since 2006, the horse ATG is not available in most countries due to the manufacturing different. And the rabbit ATG is two kinds. One is the thymoglobulin, which the dose is recommendation is 2.5 to 3.75. And the other is the ATG Francis. The ATG Francis, one study from China as studied comparing to the horse ATG. But the ATG Francis is an inferior response to horse ATG and the poor survivor. So the FDA did not approve this drug to the IST in aplastic anemia. So now the only available the ATG is the thymoglobulin. However, this thymoglobulin is used as a second-line treatment of IST who a patient who failed or relapsed case. Therefore, the first-line treatment of thymoglobulin data is limited. The first study is the Cleveland. They compared the rapid ATG thymoglobulin versus the matched historical control with the horse ATG. The response at the 6 months and the 12 months as both groups is similar. So they conclude the activity is similar between the rabbit and the horse ATG. But the other study from Brazil is a retrospective study of rabbit versus horse. However, this study demonstrated the horse ATG is a better response at 6 months comparing to rabbit ATG, and better survival of a horse ATG compared to rabbit ATG. And the NIH is a randomized study comparing to the rabbit versus horse ATG. And this result is a response at 3 and 6 months as a better response as a horse ATG compared to rabbit ATG. And again, the better survival and the horse ATG compared to thymoglobulin. We have conducted the retrospective study at a single institution comparing horse and rabbit. The horse is a 53 patient and the rabbit is a 46 patient. As you can see, the overall response at 3, 6, and 12, even 18 months, is similar both group with the horse and the rabbit ATG. However, you can see the complete response. Complete response in the horse ATG is 9, 15, 17, 22% at each time point. However, the rabbit ATG of a complete response is 2%, 4%, 11%, and 21%. So our data suggests that the complete responder is take a longer time of thymoglobulin compared to the horse ATG. And the survival between the horse and the rabbit is similar. The lymphocyte depletion after two kinds of ATG is quite different. As you can see, conducted by NIH, horse is a blue line, okay, and a rabbit is a red line. So absolute lymphocyte count or frequency of CD3 cell is very low in rabbit ATG compared to horse ATG. And the CD4 cells of frequency of CD4 or absolute number of CD4 is much lower is a rabbit ATG compared to horse ATG. And looking at the regulated T cell, is rabbit ATG is more higher compared to horse ATG. However, absolute number of regular T cell is decreased in rabbit ATG because of much lower of CD4 cells. And the CD8 cells is not much different. So this regular T cell is a decrease of the rabbit ATG, and the recovery take a long time, is reflecting that our data showing that the complete response patient has take a longer time in receiving the rabbit ATG. And in summary, the comparison between horse and the rabbit and the Brazil study and the NIH study is a better response of the horse ATG. However, two studies of Korea and one is a Cleveland study is a similar response between two regimens. However, of note, you can see the dose of the thymoglobulin. The 2.5 used in some study, and the other study is 3.5. So we do not know what is optimal dose of horse ATG. So international clinical trial is just open to comparing the different dose of rapid ATG in patient severe aplastic. And one arm is 2.5 milligram versus the 3.5 milligram per kilo. And the total number is 256. The primary endpoint is the response rate at 6, 12 months. And the secondary endpoint is EV value or reactivation between both arms. This is conducted by Korea, Japan, and China. And summary of my talk is over the last 2 decades, the standard immunosuppressive regimen for aplastic anemia has been ATG plus cyclosporine, which results in the response rate ranging 50 or 60% and improving overall survival. And the response of rapid ATG seems to be similar to horse ATG. And thymoglobulin might need more time to reach the best response after IST in comparison to horse ATG. And the cyclosporine should be continue at least 12 months after achieving maximal hematologic response, and then followed by very slow tapering to reduce the risk of relapse. And finally, optimal dose of rapid ATG to be determined. Thank you very much.
Let me just ask you one question, and then we'll come back later in the panel. So ATG is a good treatment, but it probably doesn't work only through depletion of T cells, because the best preparations were actually the least potent in eliminating T cells. So how does ATG improve the hematopoiesis in aplastic anemia? There must be something more.
Yes, as I said before, the experience of ATG in first-line treatment is very limited. So we have to prospective ATG study is justified. But we have to consider the dose of ATG. And the other important thing is a cyclosporine use, is a cyclosporine blood level is maintained to the study. And for the stratification, for allocation, as the patient have a PH clone or other abnormal cytogenetics should be considered. Thank you.
Okay, so we're going to have a discussion period at the end here, and then we'll come back to this because